and then if others join in the next few minutes, then they can. It's only the introduction. So, hello and welcome to the Alan webinar on patient-reported outcome measures. Firstly, I should say thank you to our excellent speakers for joining us. We're delighted to be joined by a variety of perspectives, and there's going to be lots of really interesting learnings, I'm sure, for everyone on the call today. Can you move on to the next slide, please, Samantha? So, welcome. I'm Zach from Whiteley. I'm the chair of the Acute Leukemia Advocates Network. Hopefully most of you will know me. And we're joined by speakers from EORTC, and I'll let them introduce themselves at the start of their presentations. I won't do them justice. And also by Professor Sam Salek, who's been involved in a lot of work with the European Haematology Association and developing HM Pro, which is a haematology specific tool. So I should say at this point, any questions you have, please continue to ask them throughout. There should be hopefully plenty of time for questions at the end. Post them in the chat so you don't forget them, but you can also raise them at the end. So without any ado, I'll hand over to EORTC, who are our first speakers.
All right, so thank you so much, Zach. So first and foremost, good afternoon from Brussels. So my name is Madeline Pei, and I've been working at the EORTC for like more than 5 years now, and I actually do a lot of like methodological support for the various quality of life activities that we do at the EORTC. So, and then I will let Dagmara introduce herself later on when she begins her presentation as well. So before Dagmara and I basically begin our presentations, we also want to thank Zach and Samantha and the rest of the Alan team for organizing this webinar and inviting us to share with all of you the EORTC's experience on developing PRO questionnaires. And we really think that questionnaire development is an area where patients and patient representatives can be involved, either as a partner to a multi-stakeholder collaboration, or actually as leads in providing evidence for the questions that are relevant for your organization and the cancer community as a whole. So we really want you all to feel comfortable while we discuss this topic. So if you have any questions or you need to clarify any points, feel free to ask them and we will do our best to respond to these questions. So next slide, please. So this is a nice cartoon strip that I usually like to use for my presentations when I talk about patient-reported outcomes. Because what I like about this is that it drives home the point that asking good and relevant questions is actually more difficult than finding answers for them. And so this is the case as well for developing questionnaires. Asking good questions to get the answers that will be useful is a much more difficult task sometimes than generating those responses. So in the next few slides, I will be presenting to you a really brief history on how the EORTC Quality of Life group answered the question, how could we assess patients' quality of life in cancer clinical trials? And how this question ended up in the development of the widely used questionnaire in cancer trials, which is the EORTC QLQC 30, its disease-specific modules, and now, of course, the EORTC item library. Next slide, please. So where did it all start? So according to the World Health Organization, the main goals of cancer diagnosis and treatment programs are to cure, prolong the life of patients, and ensure the best possible quality of life for cancer survivors. And following these advice, these are also the endpoints or the outcomes that are being assessed in our clinical trials to provide an overall picture of the risk and benefit, for example, of a new cancer treatment. So for example, progression-free survival is used to measure whether the treatment is reducing the tumor or if it is reducing the presence of the disease. Overall survival is used to identify how long patients can survive with the disease and or their treatment. And of course, health-related quality of life is used to ensure that the quality of life of patients while they are taking the treatment is not compromised or that the treatment is actually tolerable for patients. So these are very important outcomes when evaluating treatments. So next slide, please. So next slide, yeah, thank you. Because of the importance of assessing quality of life, a group of clinicians, nurses, palliative doctors, psycho-oncologists, researchers came together a long time ago because they all recognize the importance of quality of life and assessing it in a standardized way. So patients' experience throughout their cancer journey can be recorded and used as information for the risks and benefits of cancer treatment. And you have to note that these are really early days on quality of life, and even before patient organizations were formed. So, but because these clinicians and these psychologists had their interactions with their patients, they have already pointed out and realized how important it is to have their patients' view included and asked about their quality of life issues when they discuss about their cancer journey. So in the 1980s, they started to form what they call the EORTC Quality of Life Group Network with a shared interest to assess quality of life. Next, please. And in 1988, they published their strategy on how to assess quality of life. So what they realized is that they needed a generic cancer questionnaire. So these are common issues that cancer patients experience. So they can compare issues that cancer patients experience across disease sites. And then they realized they needed a disease-specific questionnaire because they wanted to measure issues that are relevant for a specific patient group that is not covered by the general questionnaire. So this strategy has been reevaluated over the years and is still considered quite relevant today. So next, please. So in 1993, the Quality of Life Group recognized, they needed to develop guidelines on how to standardize the process of developing questionnaires. And because of this standardization, the EORTC Quality of Life Group has been able to create this wonderful resource, which we call the EORTC Item Library, which Dagmara will talk about later, which is actually a library of all the items that you can have on quality of life that were developed by this group of people. And because of the existence of the item library, we can now create questionnaires that are actually tailored to the specific needs or issues of the patient group in a specific context that are not covered by the core or the disease-specific questionnaire. So next slide, please. So how do you measure quality of life? So it all starts with having a good definition of what your concept is. So here's an accepted definition of quality of life in the field. So quality of life is subjective, which means it is patient reported. It's multidimensional, which means quality of life is not just one thing or one concept, and it involves many dimensions in your life that need to be taken into account. And it's dynamic because it can change. Some of these aspects will change over time. Next, please. But then the question is, okay, great framework, right? How do you measure these various health-related quality of life issues? How does this theory come into practice? So what I'm going to show to you is just to look at one dimension of quality of life, which is physical functioning. So next, please. So here is an example of how we ask patients to report on their physical functioning. So using the QLQC 30. So there are specific items that relate to activities describing physical functioning. For example, do you have any trouble doing strenuous activities like carrying a heavy shopping bag or suitcase? And a patient can respond whether it's not at all, a little, quite a bit, or very much. And as you can see with these 5 items, they are specific questions that can be answered by the patients. So next, please. Okay, patient A can respond like this to these questions. And we know that by responding this way, this person is actually doing relatively well with regards to their functioning, their physical functioning. So next, please. Okay, but it can also be the case that another person, person B, can respond this way to these questions. And we know then that relative to person A, person B is not doing very well. And so with these measures, we can actually have an idea how a person is doing. Next slide, please. So not only can we have information to compare between groups of people or patients, but we can also use this information to track how individuals change over time. So in this example, you can see that at cancer diagnosis, or when this patient was diagnosed, the patient responded in a certain way about their physical functioning, so we can assume that they were relatively okay. And then during the start of treatment, so at month 3 of their treatment, they probably experienced some side effects of the treatment, and they could do less physical functioning activities. But by the end of the treatment, they are back to feeling better and being able to perform some strenuous activities that they were also able to do before treatment. So this is how you can compare how people change over time. Okay, next please. So in a cancer-specific quality of life questionnaire like the QOQ-C30, you can see that the items in this questionnaire measure specific issues that concerns your average, or a general cancer patient, or what they experience. So next. So you have items that look at physical functioning. Next, please. Items that really focus on role functioning, whether they're able to still do work. Then we have emotional functioning. Thank you. And then the next is on cognitive functioning. And then we have next items on social functioning, items on fatigue, items on pain, and other common symptoms like dyspnea, insomnia, appetite loss, and all of these things, right? So next slide, please. And so usually, and you notice that these issues or symptoms that you see, they don't really capture everything that you need, for example, if you have a specific cancer disease. So the QOQ-C30 is usually given together with a disease-specific questionnaire, like, for example, the QOQ-CML24, to address specific issues of chronic myeloid leukemia patients that are not covered by the QOQ-C30. And here are issues that were added based on interviews with patients. So we have more symptoms, so symptom burden. Next, please, sorry. So these are issues on symptom burden. So you can see more symptoms coming out. There are issues about their concerns about the impact of their disease on their worry and mood. Next, please. They said that this was the impact of the disease on their daily life. Next, we have body image problems. Next, please. The satisfaction with care and information, and also their satisfaction with social life. So this is just for the CML, but there's also other leukemia modules that are also available that are also relevant for this patient group. So next slide, please. So just so you know, the QOQ-C30 and its modules are not the only questionnaires that are available, right? So there are so many questionnaires out there. And the question always is, how do you select a reliable and valid measure that fits your needs? So here we're just going to give you some 5 tips, I guess, 5 suggestions on how to choose a measure. So next, please. First is you have to identify your research objective. So you have to ask yourself first, thank you, why are you planning to include a PRO measure in your study? Next, please. What issues do you want to assess from the patients that you want to give this measure to? So here's an example. Next. Yeah. A research looking at quality of life issues among, for example, CML patients for a specific treatment versus whether patients are satisfied with the care they receive from their physician would actually require 2 different PRO measures. So there's no one size fits all kind of questionnaire. That's what we're trying to say. So you have to know what you want. So next slide, please. Then you have to choose a measure that measures the issues you are interested in. So when you're thinking about which measure to choose, you have to ask yourself, has this instrument been developed and, well, psychometrically evaluated to the patient group that will be assessed in the study? So you always have to ask this questionnaire, was it tested or was it validated with a similar patient group? And second, were patients from a similar patient group involved during the development of this measure? And other questions that you can ask, next please, next and next, thank you. Or you can ask, is there an existing questionnaire that you can use? Do you really need to develop a new questionnaire? Or is there an existing questionnaire that you can adapt and validate for your needs? Because what you will learn later is that it does take a lot of time and resources to develop a questionnaire. So if there's something available out there that fits your needs, then use that, because that's what it's there for. Okay, next slide, please. And it's also important to know how the items will be scored. So we can just go through next. Okay. So how will these items be? So first is, how will the items be put together to assess a specific issue? Do they make sense for your research objective? And I think something we always forget is that, does the questionnaire actually provide a way to help you make sense of the number? So you get a number, does it really mean anything to you? What does that mean? So here you can see there are two examples of quality of life measures. On the left side, you can see that's the FACT measure. And on the right side, you have the EORTC measures. And if you look at the items, you can see that they both have items on pain, fatigue, and nausea and vomiting. Next, please. Next. Sorry about this. Yeah, okay. But they differ in how they will be interpreted. So in the FACT measure, pain, fatigue, and nausea and vomiting will be combined together with other items to measure what they call a general physical well-being issue. So the conclusion when you use these items will be about better or worse physical well-being. So in the EORTC measure, pain, fatigue, and nausea and vomiting are seen as different issues and separate issues. So if you use the EORTC measure, you will actually be making conclusions about how much pain did the patients feel, how much fatigue, or how much nausea and vomiting. So they're seen as separate issues. So what I wanted to show here is that you can have two seemingly similar quality of life measures, but the conclusions and what you can get out of them may be different. Okay, next please. Then fourth is that you have to know the track record of the measure in previous studies. So historical information about the measure is important because it provides you with additional information that can be helpful for your needs. So for example, are there published studies that have used this PRO measure? Thank you. And how can these previous studies from the PRO inform the PRO results for your current study? So next, please. So here's an example. So let's say there's a new treatment for, I don't know, for myeloma. And the question is whether the new treatment should decrease myeloma-related symptoms using the measure you will use. And then you do next, please. So you do a literature review to see what measures have been used for assessing a similar study with myeloma patients and what the results were there. So we know, for example, that there are myeloma trials that show current treatments decreasing patient-reported myeloma disease-related symptoms as measured, let's say, by the EORTC measure. So the expectation that you will have for your study is that you should at least see a decrease as well in myeloma disease-related symptoms when you use this measure. So that's the kind of questions that you have to ask yourself. And finally, thank you. And next, please. You also need to assess the practical aspects of using the measure. So how do you plan to administer the questionnaire? Is it through electronic, pen and paper, phone administration? Is it actually possible to do all of this with the questionnaire? Because you have to think that there may be patients with visual or hearing impairments, or that these questionnaires have to be given remotely. So is there a possibility to administer this questionnaire to these patients? And then you want to ask, are there available translations for your study? Are there guidelines on how to score and interpret the scores? And we always say, please, please, please read the questionnaire. Will patients be able to easily respond to these questions, or will it be burdensome for the patients? And sometimes there are associated costs in using a questionnaire, so don't underestimate that as well. So what are the associated costs if you want to use a certain questionnaire, including some licensing issues? All right, next, please. So that's for me, just to give you a broad overview of how to choose a measure and what quality of life measures are. And now I will pass the slides to Dagmara, who will give you more information on the thinking behind the development of a good PRO questionnaire.
Thank you, Madeline. So my name is Dagmara Kudic, and I've been working at the EORTC for almost 12 years by now. My main job is to coordinate the translations of our questionnaires, but over time I have been sort of getting more and more involved with other things, and one of them is really the questionnaire development at its different phases that I will now talk about. Next, please. So at the EORTC, we have two principles that we really live by for developing any new questionnaire. One is that we always include patients, and we get a lot of feedback and opinions from patients, and we always do everything in a as global scale as possible. Of course, I'm not saying we develop a questionnaire in 190 countries at the same time, but it is a very international process. Next, please. All of the questionnaires that we have follow the same module development process that consists of 4 phases. The first phase is collecting issues, then they are turned into items. We do pilot testing and field testing. Now we will go through those in detail. Next, please. So in phase 1, we collect issues, but that's done by reviewing literature, checking what there is in publications on the specific disease that we are working on and in the population in question. And we do interviews with both patients and healthcare providers who work with a specific group of patients. Next, please. The issues that we collect are really like keywords that denote any symptoms, problems, daily problems of patients, health problems of patients, as well as any adverse effects that they might have from their treatment or for general symptoms of the disease. As you can see, those are very general keywords that are collected. They are then scored by both patients and healthcare providers when it comes to importance and relevance, so that we can select the most important and relevant issues, because normally we end up with more than 100 issues and we cannot make such a long questionnaire because that would be a rather lengthy process of filling it in. So once we have selected issues, we turn them into items. Next, please. And that's a very important step where we really have to think about what we want to ask about, because an issue is very general. So if we have swallowing as an issue that patients have a problem with, we can ask about that in many different ways. We can ask about the presence of a symptom. So oh, sorry, I checked. It seems I changed my example and did not change the header. But anyway, we can ask about the presence of a symptom. So have you had problems with swallowing, or have you had fevers? Whatever, it will be a yes/no question or another response scale. We can ask about the severity of a symptom. So how much was the symptom present and how severe it was? Or we can ask about the burden that it constituted to the patient. Next, please. During that step, we consult the item library. I will later say a bit more about it, but basically it started as a database of all the items and questionnaires that have ever been developed by the Quality of Life group. And it allows for a very simple and quick search. You can just put the issue that you want to turn into a new item and see what items we already have developed, tested, translated. This way there is much less work to be done in interviews and translation and so on. Next. The next stage, once we have those items, so questions worded, is what we call translatability assessment. We do that in the ERTC Quality of Life department. And what it is, basically, we review the questionnaire to check whether there are any problems that we already know that will be a problem to the patients, and if we can solve them upfront. So those are lots of the time very like linguistic issues or cultural issues. So for example, this is a very fake example. I don't think that anybody would come up with such a really bad question, but this is something I made up to show all the possible issues that might happen in a questionnaire. So have you been troubled by not feeling satisfied or feeling blue and downhearted? First issue here, it is a very long and complex question. So it's already 4 lines in English. We know that if we translate it to, for example, German or some other languages that are, let's call it them longer, it will be a very long question and we might just lose people's attention halfway through. Then second problem that we see here, it is what we call a double-barreled question. It asks about 2 different things. So not feeling satisfied and feeling blue and downhearted are 2 things. A person can feel one, they can feel both, but if we ask it like that, they might be confused as to what we are asking about, and they will say no, even though they do feel one. It's confusing, and we should avoid double-barreled questions, and we should focus on 1 issue per question. Then we have a negative structure, not feeling satisfied. So have you been troubled by not feeling satisfied? This is a problem in translating that sentence into a lot of languages that might use double negative, or then we will not know what not at all will mean. Have you been troubled? Not at all, or very much. It does not match the response scale and becomes, again, very, very complicated. The next issue is that we have an idiom. So feeling blue, this is not something that we can translate just in a very straightforward way. In some languages, it will require a rather lengthy explanation about the emotional state, and will again become longer and more complicated for the person who will be filling in the questionnaire. We also know from experience that there are some words that are just difficult to translate. Troubled is one of them. In English, it has many hues. Having problems, having difficulty, but also it causes an emotional reaction. So this is a word that does not translate that well. We usually, when we translate questionnaires, have to choose which aspect we want to reflect. So we just try to avoid words like that when we make new questionnaires, and we would, for example, say, have you had problems with something? And then finally, we checked if a question fits the response scale that has been chosen to go with it. Because, for example, if you ask a simple question like, have you had fever? It will be more of a yes/no question than a bit to very much sort of response. Thank you. Next one. Once we have resolved all those issues, we have the questionnaire translated, because it will be tested in phase 3 in different countries. So we will need more than just the English version. The translation process is also very standardized, and we start with a forward translation from English into the language that we need. That is done by 2 people who work independently. Then those 2 versions that they created are reconciled into one optimal version by a 3rd person that reviews both and either merges them or chooses the better version, the version that uses simpler wording, and so on. So we can arrive at a better version of the questionnaire. The reconciled version is then translated back into English by 2 people again, and all those translations are sent to us for review. We focus on the conceptual equivalence, so whether the concepts that are present in the back translations correspond to what we wanted to measure with the English questionnaire. We then have a discussion with the translators to resolve any issues, and we do proofreading, and the translation can then be used on patients. Next one. So phase 3 of the module development focuses on pilot testing of the questionnaire on patients. So first, they receive the questionnaire, they fill it in, and then they are debriefed in a short interview about their experience. We check how long it took them to fill in the questionnaire, so we make sure that it's not too long. And they are asked whether there were any difficult words, any confusing words, if there was something that was upsetting, if they had any other difficulties with filling in the questionnaire, how would they ask certain questions to check if they actually understood the item correctly. And of course, we then analyze all their comments to make any necessary changes. Next one. So as a result of the pilot testing, we can make different changes to the questionnaire depending on what was reported by the patients. So for example, if they say, I do not understand this question, what is it about? We can reword it. We can add an example. We can change the structure. We can do a few changes to the wording to make it simpler. If they say, I do not know what you mean with household tasks, we can specify them as, for example, in parentheses, such as cleaning or doing laundry. We might have to retest it for cultural appropriateness, because of course in different countries, those basic household tasks might be different. And then if they say this item makes no sense, I do not worry about it. If it's something that is reported by many patients, we might decide to delete the item as it's not relevant and not necessary in the final measure. Next one. The changes made to the phase 3 version result in a measure that can be then tested in what we call field testing. It's a big study on hundreds of patients in many countries, and it measures all the psychometric qualities of the questionnaire that Madeline is much more of an expert on. So if you have questions on that, she will answer. Thank you. Next one. So admittedly, this process takes time. It's not easy. It's not cheap. It requires the involvement of many people, especially, as I said, we do it on an international level of all those phases. So what happens if you do not have 6 years to develop a questionnaire? And 6 years is actually a rather optimistic idea about development of our measures. Next. So this is where right now we can use the item library. The idea of a database, of course, that's quite simple. You put a database, you feed it, you can search through it. But over time, what we added to the item library is the option to make your own questionnaire. So this is possible by selecting items from different measures and putting them together to add on to another questionnaire that does not cover everything that you need to measure in your study. So as an example, next one. If we have a study in which we want to measure all those different aspects of the disease, next, we will use the QOQ-C30, in which we have scales that will measure nausea, diarrhea, fatigue. Next. We'll also have a disease-specific module that will cover hair loss and sore eyes. But then we are still missing a few of those symptoms. So we will make an item list with the items from the item library that will allow us to measure everything with that measurement system. We know that all the items in the item library have been validated in their original questionnaires. They have been tested on patients. They were developed following the standard procedure. They are available in normally more than 10 languages. So we are quite certain that they work quite well. Next one. So to conclude, having good questionnaires takes time to develop them. You cannot just write down some questions and give them to people. And there are lots of really really different aspects that are important. So you have to think about the wording, you have to think about the order of the items, the presentation, how they are formatted and displayed, and of course about the translations and language versions that you will need. Next. I think that is Madeline's slide.
Yeah.
Yeah.
I put this on. Yeah, okay, hold on. Yeah. So we also just wanted to say, I think at the end is that really when you develop these questionnaires, you really have to think about it. And there's really a lot of planning involved. And that we want to emphasize that the collaboration among various stakeholders, patient groups, patients, clinicians, and experts is really important to make sure that these quality of life measures or patient-reported outcome measures be helpful in delivering, useful and better outcomes for the patients as well. So that's all. Yeah.
Thank you very much, both of you, for an excellent presentation. We're going to hold questions to the end and go straight on to Sam's presentation. But just to everyone listening, there is opportunities to ask questions at the end, so please post them in the chat if you have any questions you want to ask. Over to you, Sam. You're on mute, Sam, sorry.
Here we go. Right, here we are. Thank you very much indeed, Zach. Good afternoon, ladies and gentlemen. It's a privilege to have this opportunity to have a conversation with you about just adding on what Madeline and Dagmar have very elegantly put forward. It's made my job easier, and hopefully, the things that I'm going to talk about is going to make a bit more sense. And all those issues that they raised, obviously, are relevant to what I'm going to be talking to you about today. Next, please. As a way of background, it's really breath of fresh air that we are no longer developing patient-reported outcomes or quality of life measure the way that they used to be, which was no involvement with the patients, not only as if you like, study participants, but also not at all involved in any aspect of design or conceptualization of the development of these type of measures. However, some of these measures that were developed in a manner that is presented on the slide is still being used, and in particular in oncology, in cancer patients. So the remit that I was given today was to tell you about a new PRO, patient-reported outcome measure, that has been developed specifically for patients with blood cancers, and tell you why we have developed this, and also what it is, and why there was a need for developing a new measure, despite all those things that Madeline and Dagmar have told you earlier. So the rationale for development of the HMPro was, we looked around all the measures that were used, both very, of course, little in clinical practice on day-to-day, patient going to see their doctors, and also in clinical trial of medicines for cancer, that is the solid tumors and blood cancer. It appeared that the development of these measures were based on using heterogeneous, both patients with solid tumor and hematology. So there wasn't really specifically developed for one group or the other. And these measures, of course, were used in studies, in clinical trials of both drugs that were for hematological malignancies, blood cancer, as well as the other type of cancers. Then, as Madeline explained, there were separate modules developed in order to make him a representative of particular blood cancer. There is, of course, recently one measure that has been developed specifically for myeloma and follicular lymphoma patients by a group called Osborne and their colleagues. Next one, please. So the question we asked ourselves, are the quality of life issues, the impact of disease and treatment, and the patient needs similar for patients with solid tumor and those with blood cancer? In order to answer that question, we wanted to do a literature survey, but what is usually evidence-based in terms of looking at literature to see what's out there is referred to as systematic review. The usual sort of ordinary literature review examining what is written out there and what has been reported is just a standard literature review, whereas, you know, if you do systematic review, it's more evidence-based. So we did a systematic review. Next, please. And with the objective of identifying quality of life issues important to patients suffering from hematological malignancies, to identify health-related quality of life instrument used in blood cancer patients, and also examine the suitability and validity of the identified tools in hematological malignancies. Next, please. So the issues that we identified are listed on these two slides. I hope you're able to see, you know, things such as the burden of disease, disease-related symptom, coping with the disease, and also in the group of signs and symptoms, you know, anemia, body pain, back pain, bleeding, bruising, all those sort of symptoms that are associated with hematological malignancies. Next one, please. So in summary, we found out that there are a whole host of issues that are specific to patients with blood cancer. And also we examined some of the measures that were developed for solid tumor, other type of cancers, did not actually include these specific items that were relevant to patients with hematological malignancies. Also, the important thing that was these measures were largely, the experience with them was in clinical trials of medicines rather than in clinical practice. What we wanted, this new measure that we were thinking whether it would be justified to develop, also have firstly actually have a utility in clinical practice. So when patients go to see their doctors, the doctor would be able to monitor the patients with regard to their quality of life and, you know, the burden of the symptoms. So that was lacking in the systematic review that we did. Next slide, please. So based on that information that we found during the systematic review, it's very much involved. Don't want to bore you with the detail, but it's very much evidence-based. We were able to then develop our concept. We want to develop a new measure that is specific for hematological malignancies, all type of blood cancer, as a general generic tool that would apply to all patients with having different type of blood cancer. But also we wanted this to be practical and interpretable. So in other words, your doctors, nurses, even patient themselves to be able to interpret what change of a score means on a day-to-day basis. And also we wanted this to be robust enough to be able to use it in clinical research, clinical trials of new medicines. But also having experience of development of the measure for the last 36-7 years and have developed many patient-reported outcome measures, had come to the understanding that the way to make these relevant, more relevant to patients, you got to involve not patients only as participants of the development of the measure, but also as research partners. So these were concepts that we wanted to take forward. And of course, you know, we wanted to follow the regulatory authorities such as the FDA, the EMA, the European Medicine Agency, and also we wanted to get their feedback for this development as well. Next, please. So what is the HMPRO, Hematological Malignancy Specific Patient-Reported Outcome Measure? So I hope that, you know, I've told you, you know, the background why we felt that it was important to develop this, what was the rationale, and now telling you a little bit about the HM-Pro, what it is. Of course, the name, we didn't know what we were going to call it. That, came afterward throughout the development of the measure. So as Dagmar mentioned, this is a very long, arduous process that this particular tool took about 5 years. And, this was a full-time work that we did. Initially, obviously, you need to involve all the hematological patients from the 10 different hematological malignancies that we had considered to tell us, what are the important issues, and that's referred to as concept elucidation. And then, analyze those using the appropriate analytical technique to develop themes and sub-themes, and then from those to generate the items, and then test it to see whether it does what it says on the tin. Next, please. This is a very important slide, and I want to focus on this a bit, and I've got 2 video clips to share with you. The video clips are one with the patient research partner, a patient with hematological malignancy who was involved with the project as a patient partner, as a member of the research team. And the second one is a patient with solid tumor cancer, breast cancer. And the focus of these is really to demonstrate the importance of being involved in the initial conceptualization and development of the patient-reported outcome measure. So he's developing a measure with the patients who are the target population and for those patients who are the target population. Next, please.
Just a second, I have to restart here.
Thank you very much, Samantha. Okay, well, I hope that demonstrated to you that, the monitoring and assessing patients' quality of life on a regular basis is just as important of using these measures in order to assess the value of new treatment in both solid tumors as well as in blood cancer. So moving on with the HM-Pro, which was intended, to be in the first instance useful in clinical practice on day-to-day for clinicians to be able to have a better understanding of, the impact of treatment and disease on their patients, and how they can, help them better, and also having a better understanding on those patients who are at greater risk. As Roger mentioned, we recruited 129 patients with different hematological malignancies, as you can see listed on both the left and the right-hand side of the slides. And we involved 6 different hematological centers in the UK. Also, we wanted to make sure that we have a good spread of the 3 different disease states, the stable, remission, and progressing. Next slide, please. Now, one of the important things is that what we actually managed to find in our systematic review in terms of the issues relevant to patients with hematological malignancies were replicated when we did our qualitative interviews, what patient told us. So how well we can actually see superimpose both. So you develop a framework from those that you get from the literature, and then you do your empirical work, actually asking the patients what is important to them and what are the issues coming up, both in terms of the impact as well as the signs and symptoms. And then, you develop a new framework in order to have the full picture. As you can see, these majority of those impact on the left-hand side, sorry, are similar to those other issues that we looked at before, and the same with the sign and symptoms and the treatment side effect. Next one, please. So once we developed these qualitative phase and completed the instrument, as you know, Dagmar mentioned, then starts the development of the prototype measure, generating these items from the themes and the sub-themes that has been generated through the interviews. So all those issues that Dagmar mentioned, you know, you have to consider at this phase. Also looking at the, you know, recall period, you know, whether, you know, you want to use statements or questions, etc. So we took the qualitative data that we had through the interview, through this process, and these were the people that they were involved, and we were locked into a hotel room for 2 days with 2 hematologists, 1 patient research partner, 1 patient representative, and 4 PRO methodological experts. And finally, after 2 days, you know, 10, 12 hours a day working on this, we came up with the prototype HM Pro, which then we also decided that we wanted to overcome some of the inefficiencies or perhaps inadequacies of the other measures that have been used by developing a composite measure having 2 parts, 1 part to be the quality of life aspect, and the second part, the part B, to be the symptoms and the side effects. Next one, please. So then we took the measure next to the next phase, which is the cognitive debriefing or content validity, to establish whether the focus and the emphasis of the measure is fit for purpose. And the only way to do that is by going to the target population. Again, different group of patients with blood cancer were involved in this process. And you can see there are different steps that we took this through. Next slide, please. The outcome of it was that everybody felt that the items in the measure were relevant. Mathematically, we also measured this, and it gave us a good mathematical value and confidence in the measure, that the measure was relevant to the population. Even though we were, you know, convinced that it would be, because it came, you know, determinant came directly from the patient, but it's still, you know, you have to take it through this very systematic approach to establish that the measure is relevant and fit for purpose from the patient's point of view. Next one, please. Then other things that we asked patients was, you know, whether they prefer to be in a form of a statement, all the different items, whether it would be, would prefer to be in a form of a question. They preferred to be in a statement. In terms of the part A, we asked them, would they want to be in a form of a present today, rather than, you know, last 3 days or last week. Majority preferred that they wanted to be today, at present, the recall period. And the recall period for the item as part B, the symptoms, they prefer to be the last 3 days. We asked a number of other things from the patients, even as, you know, for the paper version, we also asked them which color they prefer to be. But of course, simultaneously, we were establishing the measurement properties of the HM Pro, both for the paper version as well as the electronic version. We wanted at the end to demonstrate that they were equivalent, whichever way you collect the information. Again, this is something that Dagmar and Madeline referred to in their talk. Next one, please. So the result of the item reduction, or this refining process that we took the HM Pro through, was that we started with 35 items, statements in part A, and that process we ended up with 24 items. For part B, the sign and symptoms, we started with 23 as the prototype measure. We ended up in 18. So the HM Pro has got 24 items in the impact the quality of life part A, and 18 in the part B, signs and symptoms. We of course applied both the traditional and the sophisticated modern techniques referred to as factor analysis and item response theory in order to get to this. It's a very long-winded process, which I don't want to bore you with the detail. Next slide, please. So after establishing that, we wanted now to find out whether this questionnaire is valid, reliable, can it be administered repeatedly without losing its precision, and also is it sensitive to change over time. So we tested the questionnaire for all these by having 3 different administrations. The first administration was done in the clinic, and the 2 other administration were done by post. We also repeated the same approach with the patient membership of the Hematological Malignancy Patient Organization. Next slide, please. So the measure, through going through those different techniques of establishing reliability, the outcome was that measure was highly reliable with a minimum degree of error. That's really what it means in both repeated measurement, different time of application, and it was proved to be robust. Next one, please. In terms of the equivalence study, we wanted to establish that whether the paper version and the electronic version are equivalent. Again, the outcome of that was very satisfactory, and we confidently could say that the measures can be administered both paper version and electronic version, and having the same result and reliable and valid results. Again, all these information that I'm presenting to you have been published and available to be examined. Next slide, please. Again, we compared, which is a standard technique to compare the new measure with established measures, and we compared it with 2 measures that was already mentioned, EORTC-QL Q30 and FACT-G, and again the outcome was very positive. The questionnaire was valid throughout, having taken throughout this process, established and standard process. Next one, please. In terms of the responsiveness, whether it's sensitive to change over time, again, this is standard way of demonstrating that, and you can see those red p-values. That means that the HMPro is capable of detecting change over time, even though small but clinically important. Next one, please. So there are 2 important aspects of interpretability. Being able to interpret what has a change to a score means from one visit that you are prescribed a new treatment, and the next visit that you come to see the doctor to see how this treatment is worked. How does the clinicians or the patients themselves actually interpret that score? In the clinic, we usually recommend to use a banding, which a technique used called anchor-based technique, and for the clinical trial, something that is called minimum clinically important difference, and that's what MCID is on that slide. So we established the MCID for clinical trial to be, for both part A and part B, to be 6. Next slide, please. But in terms of the banding, which is an interpretation or finding the meaningfulness of the scores in a routine, busy day-to-day clinic that the patients are being assessed, it's a technique that is used predominantly for that purpose. Next slide, please. So doing that, we established these range of scores and their meaning attached to it. So very easily, because that will be printed, whether it's electronic or paper, at the bottom of the questionnaire, the clinicians will be able to look at that and be able to interpret the change of a score. The important thing is that we did several reiteration for both male and females. And the conclusion was that the banding was equivalent for both genders. There was no differences between the two. So the clinicians can confidently use these banding scores for interpreting the scores on a day-to-day busy clinic, and being confident that, you know, one banding can be used for both male and females. Next slide, please. So well, the app is available for HM Pro. That was another part of the development that we wanted to complete at the end, and it's available for everyone to use. And you know, if you complete the questionnaire, it also gives you, you know, what it means, those different color that you see for part A and part B, and the different, of course, section, which is physical, social, emotional, and eating habits. Next one, please. So the questionnaire has been translated, which again, you know, through the development, we were mindful of the translatability and universality of the items. And it is now available on these languages that you can see on the screen. And also they're available on the website as well. Next slide, please. So to bring this to an end, I would like to submit to you that since the HM Pro has been developed with the involvement of all the stakeholders and regulatory guidelines, in particular, a strong involvement of patients, clinicians, and the pharmaceutical industry, it should become the standard of care in clinical practice of hematological malignancy, as well as the instrument of choice in clinical trial of new medicines involving patients with HM. I hope that's been useful, and be happy to answer any questions.
Well, thank you to all of our speakers for some really interesting presentations, exciting. I think lots of takeaway messages for everyone there as to understanding the key role of patient-reported outcome measures across hematology. We have already overrun somewhat, so I'm not sure we've got any time for questions, unfortunately, because I know some people have already had to head off for another meeting. But I'm sure if anyone has any questions, that our speakers would be more than happy to take them separately via email. So everyone should have the contact details for Samantha and myself. And if you have any questions separately you want us to put to the speakers, we're more than happy to facilitate that separately and after the webinar. But I'll just say again, thank you very much to our speakers. It's been so useful and so helpful content for everyone involved. A copy of the recording and the slides, etc., will be shared with everyone who's been with us today, if you want them for future reference. And particular thanks to our panelists from abroad who are now heading off to join their bank holiday weekend and giving up the last bit of a long and busy working week to join us. So thank you very much to everyone. Take care, and I hope you have a good rest of the day.
Thank you.
Thank you very much.
Thank you very much indeed.